Good morning, Roger Quesada here from the American Hip Institute. We will discuss about today the non-operative treatment for hip arthritis, from physical therapy to regenerative medicine. Hip arthritis is a degenerative condition that causes progressed loss of cartilage within the hip joint. Normally, symptoms can start gradually. People start complaining they feel the joint as they go by their daily activities. It will progress over time, and normally by the time they consult, they complain of pain when walking, when going up and down the stairs. Just standing will be difficult for them. It normally presents with some associated symptoms. This could come from any of the surrounding tissues around the hip joint that get some inflammation. From the anterior side, the iliopsoas tendon could get involved. From the lateral side, some of the bursa and might be some tendinitis of the gluteal muscles as well. Anterior side, the piriformis or any irritation of the sciatic nerve could be associated with hip arthritis. Speaking about the risk factors, we have modifiable ones and non-modifiable ones. The modifiable ones, we speak about anything that causes articular trauma, muscular weakness, any high-impact sport, running, weightlifting, these kind of activities, high-impact loads during work, and obesity. And in the non-modified ones, we have the gender, normally affected more the females, age, elderly people will suffer this condition, and any kind of inflammatory arthritis such as lupus or rheumatoid arthritis are normally at risk. Diagnosis can be easy made by the physical examination, clinical history, and with a plain X-ray. Normally, we start seeing some osteophytes, some narrowing of the hip joint space, and sclerosis surrounding normally the weight-bearing areas. Briefly to speak about one of the grading systems we use. This one is the Tony's grade classification, which 0 means no signs of arthritis, 1 some sclerosis, mild narrowing of the hip space. The number 2, there are some subchondral cysts, some moderate sclerosis, and then type 3 is like bone-on-bone hip arthritis. After we establish the diagnosis, we always will start with the non-operative treatment, which here education is key. Lifestyle modifications, we have pain medication, we have physical therapy, some additional therapies as cold laser, dry needling, injections, so we have the biological injection and the steroids. But the most important part here is education, and the patient has to understand that all these measures are to improve the symptoms and to get some relief of the pain they are feeling, but they won't really treat the main source of the pain. So for the lifestyle modifications, we normally instruct people to control their weight, go to see a nutritionist, work modifications when it's possible to decrease the loads, exercise involving high impact activity as running should be diminished, and try to go to non-impact activity as cycling or swimming. In more advanced stage, the use of a walking stick on the contralateral side will be beneficial to decrease the load on the affected hip. An article that was published in the BMJ in 2012. They follow people that manually handle loads over 20 kilos. They found that if they were exposed for over 10 years, the risk increased by 2.2, and if they continue for over 24 years, the risk increased up to 4 compared to the non-exposed population. This article was published in the International Journal of Obesity in last year. They follow 8,000 people with knee or hip arthritis. They found that every 1% of weight loss decreased the risk by 3% of getting a joint replaced in their life. In terms of pain medications, we normally start with some basic NSAIDs or over the counter, going all the way up to opioids as needed to control the pain. There's been new research about the use of cannabis in this sort of pain. It might be beneficial in order to decrease the amount of opioids we're prescribing. Physical therapy should be individualized, should focus on any muscular deficit they may have, focus on the strength, kind of balance all these muscles around the joint, working again in range of motion and on the aerobic capacity is important as well. These slides, we have a short video illustrate the different stages we should go through with every patient. Again, every therapy should be individualized to check the ability of the patient to do it. He's showing some of the progressions from sitting position, standing, and laying on the ground. Patient, we should focus on the movement control, balancing the gait of the patient and all the muscles around. Again, most important part, as we believe, is to individualize the therapy. Some patients will be starting on the most basic progressions, and some other could even go and add some extra weight to the exercises. A study published in the Clinical and Experimental Rheumatology 2020. So, as general recommendations, they defined the first line of treatment, supervised exercise, pacing, education, and weight loss. If that's not sufficient, we could do for the knee some bracing, some manual therapy, passive range of motion, working on balance of the muscles around the joint, pain relief. Here is where we could add some of the injections, and then if none of this seems to work, going to heavier pain medications and to referral to a surgeon to consider surgery. So this is from the same paper, 8 recommendations exercise for the knee and hip arthritis. First one, offer patients supervised progressive aerobic and resistance exercises. For the weaker population, water based exercise is a good way to start. Every 2 weeks, reassess and readjust the treatment. Offer patients education material will improve the compliance and the long-term effects. In general, the conclusion is if we give them supervised exercise and individualized therapy, everyone will improve to some degree. So discussing about possible add-ons therapies, we have the manual therapy exercise, passive range of motion is beneficial for a patient in the short term, and dry needling around the hip in patients with hip arthritis proof to relieve the symptoms in patients, again, in the short term period. Cold laser therapy is a great option that we also have here in the American Hip Institute for our patients. By using low-level lasers, we produce biological response, photobiostimulation of the surrounding tissue, decreasing the levels of inflammation and helping with the healing process. In terms of this photobiostimulation clinical effects, we are able to improve the angiogenesis in the area, giving more blood flow to the area. We decrease the scar tissue formation, promoting elasticity within the collagen fibers. We promote the muscular tissue regeneration. In general, it will decrease the inflammations around and will produce a more healing environment for the zone we use this therapy. So going over the benefits, we have less inflammation, will translate in pain relief, faster healing, better healing for the different tissues, muscle, tendons, joints. It will be beneficial even for neurological pain. It's a non-invasive therapy and it's a candidate almost everyone that acute or chronic tendinopathies, sprains, people after any trauma, any type of local inflammation could be treated with this cold laser therapy. Goals again is to reduce pain, reduce inflammation, and promote tissue healing. So another option, working with the physical therapy, we have the injections. We have two main types of injections: the biological ones, PRP, BMAC, hyaluronic acid. Hyaluronic acid is not approved for the hip; it's only for the knee. And we have the well-known cortisone or steroid injections. Inflammation. So the platelet-rich plasma, as we know, is produced by centrifugate the patient's own blood. It will contain growth factors and cytokines that will decrease the inflammation process, will speed up the healing process, will regenerate some of the damaged tissue, and promotes an anti-inflammatory environment within. So in a normal blood sample, we have around 6% of these growth factors and cytokines. When we go through the process of these centrifugates, we are able to concentrate those growth factors and cytokines in this sample, representing the 95%, which is around 5 to 10 times the concentration of the normal blood. In rheumatology, where they follow 40 patients with severe hip arthritis and they receive PRP injections 1 per week, them up for 6 months. So we see here on the charts that both of the PROs got improved at 6-7 weeks and then at 6 months mark. An article published in 2020 in the Hip Preservation Surgery Journal. Again, they had 9 patients, 11 hips, between 35-year-old and 75-year-old, and they report the outcomes at 3 months, 6 months, and 1 year. And we see that all the PROs improve over this period of time and was sustainable all over the year mark. So the bone marrow aspiration, or BMAC, is where we draw a sample from bone marrow. We have different places that we could take it from. We do this harvest, then we concentrate on a centrifuge, and we have this marrow aspiration concentrate ready in less than 15 minutes. So what we aspirate and concentrate from the bone marrow are the mesenchymal cells. These cells have the potential to differentiate themselves from different tissues and go into tendons, ligaments, or articular cartilage. So it will improve the healing of any of these tissues. So the BMAC has some advantages that we take it from our own body, so there is no rejection. It promotes natural healing by these cells differentiating in different damaged tissues. It's an important option to people that are not ready for surgery or as an alternative therapy. Disadvantage, when as it's an invasive procedure, so the risk of infection is always there. They could experience some pain in the donor side, and normally they are not covered by insurance. This is a prospective study that was published in 2020 from the Orthopedic Journal of Sport Medicine. They had 18 patients that received a single shot of BMAC and improved pain over the next 6 months in patients that were symptomatic with hip arthritis. Different type of injections, not biological. The steroids have been well used over the years and has some recognized advantage. There are some anti-inflammatory medication, so it help with pain relief. Sometimes it helps with the diagnosis. We could target some of the intraarticular or extraarticular structures to see from where the pain is coming from. It's an office procedure. It's covered by insurance. Disadvantage is people experience short-term relief pain. Some people could get lucky and get like 3 months, but some others just a couple of weeks. In patients with diabetics, we have to be careful because it could spike the sugar levels. It might be chondrotoxic, and again, these are invasive procedures. The risk of infections are always there. So in general, hip osteoarthritis, and then we have a lot of different treatment options that we can go through every patient, but the most important one will be the education. So for the pain control, we have the painkillers and the different types. Then physical therapy is always key in this treatment, working on range of motion and strength. Then we have different type of injections and different type of treatment that's called therapy, PRP, BMAC, or steroids. And if nothing seems to work, we can always refer them to consider a surgery. In this case, it would be an arthroplasty. And that's it for today. Thank you.